Hi everyone. I'm going to be talking about germ cell tumors, as Prof has said, but my main emphasis is going to be on Sacrococcygeal teratomas, and then I'm also going to mention a few of the more common teratomas. Okay, so the germ cell tumors are a relatively uncommon group of neoplasms. They are basically masses of tissue that are formed by immature cells that normally would have developed into either a mature egg or sperm. So they can be located anywhere throughout the body. They either can be gonadal or extragonadal, and the location of the tumor often determines the timing of presentation. So the tumors that are located intra-abdominally, the ones that are in the pelvis, like your ovarian tumors, abdominal tumors, they can present late because of the space that they have to grow, whereas the others like testicular tumors, they might present earlier, or they can be diagnosed earlier. This is an image that I got that helps with understanding germ cell tumors as a whole, even though I won't be going into the seminomas and the dysgerminomas. I will mention on the embryology in a few slides. But when it comes to germ cell tumors and how they are thought to arise, it's mainly as if there's a problem with the normal migration of the germ cells. If there's an aberrant migration, that can lead to germ cell tumors. So the normal migration, as you can see here, is to the gonads, but if there's any abnormal migration, that's where you get the extragonadal germ cells. And then that's where you can, if there's a presence of neoplastic cells, you can get, if they're in the gonads, you get seminomas or dysgerminomas, and then the embryonal carcinomas give rise to either embryonic or extra-embryonic. The embryonic tumors are further divided into mature or immature teratomas. And then the extra-embryonic, that's where you get the choriocarcinomas and the yolk cell tumors. These are the malignant, most of them are malignant tumors. The teratomas are mostly benign tumors, even though they might become malignant, which is what I will go into later. This yolk cell tumor was previously known as the endodermal sinus tumor. That's why that is in brackets. And then just on the classification, I did mention with the anatomical classification, you get gonadal or extragonadal, and then seminoma versus non-seminoma tumors, and then benign versus malignant. And then there's another classification that I did mention where they're classified based on the histology, mature, immature. So the mature ones have mature elements like skin, hair, fat, tissue, cartilage. And then the immature teratomas, they have immature elements like neuroepithelial tissue and immature mesenchyme. This is just a slide on the basic genetic terms. So when it comes to all tumors, it's important to understand these genetic terms. DNA ploidy is a measure of the DNA content within tumor cells. So cells that are in the resting state, when they contain one complete set of chromosomes, they're known as diploid, which is when you represent it numerically, it's 2n. They have one complete set of chromosomes. Tetraploid contains double the number of chromosomes, and then the aneuploidy is somewhere in between. This is when you might get an extra chromosome or one less chromosome than normal. So what I was able to find that is in line with the presentation today is that the teratomas, most of them are diploid, whereas the germ cell tumors, some of them can be diploid, some are tetraploid, and then aneuploidy. An example of aneuploidy is that the most common one that we know is the trisomies 13, 18, and 21. That's when you get an extra chromosome. And then when it comes to embryology, there are 3 theories that have been described as to what might be the cause of the germ cell tumors. But the first one is the one that is accepted. So they are total cells which develop among the endodermal cells of the yolk sac and migrate to the gonadal ridges during week 4 and 5 of gestation. So if there's any aberrant migration or they are halted on the way to their normal site, that can lead to germ cell tumors wherever that may be. And then the second theory is that they might arise from remnants of the primitive streak or primitive node, and that's around week 3 of embryonic life, where you get the formation of the primitive streak and primitive nodes. Those remnants are also pluripotential, so they have the capability of they have the capability of being germ cell tumors. And then the third theory, and this is supported by the fact that when it comes to germ cell tumors, they may be associated with, there's an association of a family history of twins, or in some cases you might have what they call fetus in situ, where they find some components which might seem like the one twin or something like that. So some people might consider them as part of the spectrum of twinning or conjoined twins. So this just a representation of what I was talking about with the, I'm not sure if this pointer is showing, but the first part of the picture, it shows the first, it's a representation of the first theory, where you get the primordial germ cells at the base of the yolk sac, and supposed to migrate, and then the other picture, it shows the primitive streak with the primitive node, with also those migrating cells. And then teratomas, they have a variety of presentations which affect It might affect the fetus, the infant, child, and adolescent. They form from all three embryonic layers, ectoderm, mesoderm, and endoderm, and there's also been a monodermal type that has been described. They are composed of multiple tissues foreign to the organocyte from which they arise because of the pluripotent nature of those primordial germ cells. So many of the tumors, they might contain skin elements, teeth, all those things. Sometimes they have more organized tissues, even a beating heart, which is called a fetiform teratoma. And there's also this that has been described, fetus in situ, which I talked about earlier. Teratomas, even though most of them are benign, they may also develop or contain foci of malignancy. Also to mention, a malignant germ may also be found, as I mentioned, with the teratomas. Malignancy at birth is uncommon. It increases with age and incomplete resection. So the children that present later in life, or those who had surgery but complete resection, that may progress to malignancy. This is to mention the tumor markers that are associated with germ cell tumors. So the yolk cell tumor, which is the common type that is found in the Sacrococcygeal Teratoma, it secretes AFP, so that is clinically significant because we have to monitor the AFP pre and post-op. And then some of these tumors might secrete beta HCG if they have choriocarcinoma, and that leads to precocious puberty in most of in those patients. And then some tumor markers that were mentioned, the CEA and CA125. But some texts did not mention this, but I added it anyway. And then when it comes to the genetics of germ cell tumors, it's not yet understood. In some cases, in adults, they had found in the short arm of chromosome 12, they thought what they thought might be the cause of germ cell tumors, but this is not validated. So, yeah, they not yet. It's not yet understood. And then in some kids, they had found deletions in chromosome 1 and 6. But as I said, it's not yet quite understood what all of these mean. Okay. And then, okay, associated anomalies with germ cell tumors, they're usually isolated, but if you have any associated anomalies, these are the ones that I could find. They mentioned the Currarino triad, which involves an anorectal malformation, a sacral anomaly, as well as a presacral mass. These patients, the anorectal malformation is usually an anal stenosis, and then you find a sacral anomaly and a presacral mass. They mentioned that presacral mass is usually a sacrococcygeal myelomeningocele. And then in some patients, they in 1974, they found an autosomal dominant inheritance pattern, and Yeah, so there is an element of familial predisposition. And also in some patients, especially the patients with currarino triad, the MX1 gene has been isolated in the phenotypic patients. I mentioned the family history of twins. Another one that is important to mention is the Felter syndrome, which is strongly associated with the mediastinal teratomas. And then Sacrococcygeal Teratoma, it's the most common tumor in a newborn. It has an estimated incidence of 1 per 35,000 to 40,000 live births. And it has a female to male preponderance of 3 to 4:1. Differential diagnosis for this, it can be a meningocele, lymphangioma, lipomas, meconics, and other things which are not so common. Sorry. Okay, so when it comes to the classification of the Sacrococcygeal teratomas, we use the Altman classification. There are 4 types. Type 1, the mass is predominantly external. And then in type 2, it is external, but there is some intra-pelvic extension. And then with type 3, most of it's intrapelvic as well as abdominal. And then with type 4, it's entirely presacral mass. The most common, it's basically according to it's 4 types. So the type 1 is the most common, close to 50%, and type 2 is 35%, with the rest being around close to 9% each. And also the image that I put in here, it shows the different presentations. So this would be the top one, an image of a neonate with a giant ruptured sacrococcygeal teratoma, and at the top would be an infant that presents with a malignant sacrococcygeal teratoma. I'm gonna with the prenatal diagnosis. It's usually diagnosed on second trimester ultrasound. The perinatal mortality is related to prematurity or tumor rupture with exsanguination. Some of these tumors can be highly so it might lead to even a risk to the mother. The mode of delivery, a Caesar is advised, especially if the tumor is more than 5 centimeters, or if the tumor itself is larger than the fetal biparietal diameter. And they also mentioned that maternal mirror syndrome, which is a syndrome basically which mirrors what is happening with the fetus. So in these children with the sacrococcygeal teratoma, some of them might develop hydrops fetalis, which is basically fluid accumulation in the compartments. So with the mom might also have the same kind of clinical picture happening. So once that is diagnosed, this maternal mirror syndrome, it might, it's an emergency, which means that you have to expedite delivery and do an emergency Caesar. So mom usually, they mention it's quite difficult to diagnose it, but it's characterized by mom having proteinuria, and also basically symptoms that are quite similar to preeclampsia, as well as edema, all those things. So if a tumor is larger than the fetal biparietal diameter diagnosis, and also if it grows faster than the fetus, or with the fluid, if it's 150 mils per week increase, then that is associated with a poor prognosis. Other things that you might be able to see and which show worsening condition of the fetus and signify impending fetal death, the placentomegally, hydrops fecalis, as well as fetal anemia. Okay, so there have been a number of interventions for the fetus that is diagnosed with Sacrococcygeal Teratoma. Open fetal surgical excision or debulking, that is usually described when the fetus is less than 28 weeks. And then the exit procedure as well has been described. And then there are a number of minimally invasive procedures, the laser ablation, the radiofrequency ablation, alcohol injection, and then the percutaneous aspiration as well. But that is only for the purely cystic teratomas. All these minimally invasive techniques are in the works, I would say. I found a study here that is talking about, it's describing the outcomes of minimally invasive antenatal procedures for treatment of fetal sacrococcygeal teratomas. So the first was a case series, and then they did a systematic case review of the literature. There were the case review, they had 5 fetuses with a large SCT, and they did laser ablation and RFA. The outcomes of that case series, they had 2 intrauterine fetal deaths and 3 preterm labors, and this happened within 10 days after the minimally invasive procedure. 1 of these neonates died, 2 survived without procedure-related complications, but they had morbidity that was related to prematurity. So the conclusion from this was that even though fetal therapy improves perinatal outcomes for hydropic fetuses, and this was for solid SCTs, it's often complicated by IUFDs and prematurity. But even when they did the systematic case review of the literature, I think they said about 30% of the neonates out of 20, they combined with their case series and the systematic review, 30% of the neonates survived. And then diagnosis and workup with the neonatal presentation. It's usually an obviously visible mass at birth. Yeah. When it comes to this, you have to, they mentioned you have to differentiate it from meningocele. So they mentioned that if you press gently on the mass, if it's a myelomeningocele, you'll get bulging of the anterior fontanelle. And then with the infantile presentation, they present later. So they might have constipation, urinary retention, abdominal mass, or even symptoms of malignancy, failure to thrive. And then of note with the examination, you have to do a rectal examination to assess the intra-pelvic component, yeah. And then you need to document neurological deficits prior to surgery, because after surgery there are some you need to know if any neurological deficits happened before or after you performed the operation. Serum tumor markers are important. You need to check the AFP, and so that you can compare it with post-op as well. It's supposed to decrease and get to normal by 9 months. So if there's any increase in AFP after that, that signifies a recurrence, or there was some tissue that was left behind, which is now malignant. And then with the radiography, as I mentioned, X-rays, and all these, the MRI is also important. Yeah. Okay. Operative approach. For the neonatal presentation, if these kids if they present during the neonatal period, it's usually resected in the first week of life. You can choose which operative approach you go with, either prone versus supine. It depends on a number of factors. You might choose to do the supine is usually like for the abdominal approach, if the tumor is highly vascular. Yeah, for the highly vascular tumors, or the ones that are predominantly intrapelvic and abdominal, it might be better to go for the abdominal approach. And then, but most of them you can go for the prone position. So what is important during the operation is the excision of the mass, including the coccyx. There's a 37% recurrence if you don't remove it, if you don't remove the coccyx. You need to ligate the middle sacral artery, and also appropriate reconstruction of perianal musculature, taking care to do the operation according to the plastic surgical principles in order to get a good cosmetic result. And then after the operation, follow up is with serum AFP levels as well as rectal examination, 3 monthly up to 3 years of age. This is just an image that shows the operation, basically how you would go about removing the mass. The incision that is described is the chevron incision. It's a V-shaped incision, and then you remove the tumor. You transect the coccyx. You ligate the middle sacral artery, yeah, and all those things. And this is for the difficult or unresectable teratomas. The approach is slightly different. If the tumor is it's difficult or unresectable, you might need to first do a biopsy to confirm, especially with the with the kids that present in the infantile period. They usually might be a malignant SCT, and then they will need chemotherapy. It's platinum-based chemotherapy, which has changed the prognosis for these kids. They mentioned that prior to 1978, there was an 11% survival rate, which improved to 86% after the platinum-based chemotherapy. These kids are usually given cisplatin, etoposide, and bleomycin. And then once the tumor has shrunk enough, then you can excise the tumor. Another term that I came across that it's a growing teratoma syndrome. I just thought to put it in here. It's a rare condition, but it's clinically significant. It's caused by in these teratomas when the benign elements of the tumor continue to grow. A case that they mentioned that is worth saying is they mentioned a 4-week-old child who presented with a teratoma, had normal tumor markers, and had this large mass that they decided to treat with chemotherapy for suspected malignancy. But when they did follow up imaging, the tumor had grown significantly, even though the tumor itself was benign. So what they mentioned here was that with the growing teratoma syndrome, the tumor needs to be the gold standard. The tumor needs to be excised, and the learning point from this, I can say, is that once a child is on firstly the chemotherapy, there has to be a definite diagnosis of malignancy before you start the chemotherapy. And then once a child is on chemotherapy, they advise that after 2 cycles of chemo, you need to continue doing imaging to check for any subtle changes in the tumor. Yeah. This is the staging system that I found for the malignant extragonadal tumors in childhood. This applies to SCT. Most of the sacrococcygeal teratomas fall into stage 1, but after surgery, you have to stage the tumor. So this is just the staging. And then when it comes to prognosis, firstly, they did mention that the prognosis with the sacrococcygeal teratoma is quite good. They actually said it's excellent. Age is a predictor of malignancy in sacrococcygeal teratomas. So the ones that are, the malignancy is less than 10% at birth, but after 1 year, more than 75% are malignant. An exception to this are the ones, the familial pre-sacral teratomas and incompletely excised lesions. Yeah. And then there's some factors that contribute to poor prognosis. The ones that are prenatal factors are the prenatal high drops, shoulder dystocia, tumor rupture, prematurity, those highly vascular lesions and lesions that are more than 10 centimeters. And also they mentioned that a fetus that has an in utero diagnosis has a survival rate that is more than 90% if the tumor is small or if it's discovered on routine prenatal ultrasound. But if the ultrasound was done because of a complicated pregnancy, then that is associated with a 60% mortality rate. Okay, this is another.
Vuyo, sorry, shall we shift to a second meeting? We just have less than 1 minute, so we
Okay.
will end this meeting
Sure.
and start the next one. Okay.
Okay.
You can start, Vuyo.
Okay. This is another. Sorry. Okay. This is another study that I found that was just mentioning. I was looking for something that mentioned South Africa, but I couldn't find information with us. But this involves they did a study and they took information that was published from countries in sub-Saharan Africa. It includes Uganda and Nigeria. But the main thing that I wanted to say with this was that most of the children here in sub-Saharan Africa, they present late, and the ones even like as they present late when the tumor complications have already set in, and also because there's a delay in presentation that is usually due to lack of access to healthcare, and other complications are that they don't have specialist pediatric surgeons. Yeah, so but they mentioned that they need more multi-center and long-term data, but this is also applicable to us. And also they mentioned that they experience a lot of obstetric complications because these the moms aren't they don't book, so there's no antenatal care, so that the diagnosis is not made in utero. So some of these moms present in like with shoulder dystocia, with massive bleeding and all those things. And then I'm just gonna go through the other sites. With the testes, the most common type of benign neoplasm in boys that are less than 3 years. Most of them present with a painless testicular mass, but others do present with an acute scrotum with signs and symptoms of the kids, usually the first line of investigation is a scrotal ultrasound, followed by serum markers, abdominal and chest CT. Surgery is by a radical osteotomy, and they also mentioned that the small encapsulated cystic mass can be nucleated. The approach for this is a transinguinal approach. And then this is the staging system for the testicular tumors. And then with the ovary, the ovarian ones, the 80% of them are benign with predominantly cystic components. They comprise about 40% of all ovarian tumors. 10% of them are bilateral. They may be cystic, solid, or mixed with calcification. The kids can present with pain, distension, a mass, acute abdomen, as well, and also precocious puberty if there's a choriocarcinoma. The approach for surgery is either open or laparoscopic. They mentioned that open, if the tumor markers are high, or the tumor itself is predominantly solid, it's advisable to go for the open approach. If you do choose to go for the laparoscopic, especially for the cystic ones, it has to be surgeon with expertise to avoid tumor spillage. And then you need to monitor serum AFP levels pre and post-op. Then this is the staging system for the ovary tumors. And then I'm just going to go through a few clinically significant teratomas. The cervical teratomas, 8% of all teratomas. The 8% of all teratomas, they're usually benign. They often lead to severe polyhydramnios. And another important thing about these is that they might cause tracheal compression, which would lead to airway obstruction. They mentioned that without the respiratory distress, they have the neonates have a 2.7% mortality rate, while the rest distress is associated with a 43.4% mortality rate. So they mentioned that respiratory distress is an important prognostic factor when it comes to the cervical teratomas. The differential diagnosis, and as I've written there, cervical lymphangioma, congenital goiter, etc. With these children, it's good that when it's diagnosed in utero, because you can make a plan, especially with the neonates that have airway obstruction. So the exit procedure has been very beneficial for these kids, and it has to be the anesthetists also have to be present here, because this is quite it's difficult to secure the airway with these kids. Complete excision in the newborn period is associated with 80 to 90% survival rate. And then thoracic teratomas, they are 7 to 10% of all teratomas. The anterior mediastinum is the most common site. So I'm just going to mention on the mediastinal teratomas. The other sites, intrapericardial, intracardiac, and pulmonary, are less common. The main presentation with these tumors is respiratory distress, autopnea, hemoptysis, chest wall tumor, and some might present with precocious puberty. If these kids present at more than 15 years, there's a high incidence of malignant behavior. With these tumors, they also have to be excised, and the approach, you can go for either median sternotomy or thoracotomy. Other sites which are less common. And then with the conclusion, the survival for pediatric germ cell tumors has improved since the introduction of platinum-based chemotherapy. Prenatal diagnosis and repeated ultrasounds ensure safe delivery, as well as option for intervention prior to delivery. Most teratomas are benign and have excellent surgical outcomes. SCT is the most common neonatal tumor with a worsened prognosis in delayed presentation and recurrence. And then follow-up involves serial serum tumor markers as well as examination. Long-term follow-up is necessary due to long-term sequelae in some patients, which affects quality of life. Done.
Yes. Vuyo, this was very comprehensive. It was excellent, and you covered all the aspects. I'll invite comments in a minute. I just very few small things is that a solid variety of sacrococcygeal teratoma, whether it is diagnosed prenatally or even postnatally, has worse prognosis than a cystic component. And obviously a large solid intrapelvic intra-abdominal component, you cannot excise through a prone position and pre-sacral approach. You will need, as you said correctly, laparotomy. So that is one more factor to be added to prognosis as well. And just one more thing about prenatal intervention is aspiration, which I think you mentioned, but also shunt from the cystic tumor into the amniotic cavity. That has also been mentioned, but you mentioned all other fetal interventions very well. And just last one, tongue in cheek, I liked your sub-Saharan African reference, but there was one reference from our department, which was long time ago. I think it was 98 or around that time. There was a newborn with huge cervical teratoma, and after excision, the patient developed hypothyroidism. So it was reported in Pediatric Surgery International that after excision of cervical teratoma, you can get hypothyroidism. It's not mandatory, it's just out of interest. Okay. I'm going to invite Yashoda to make comments or give some added information. Yashoda?
Yes, hi everyone. Thanks to you, that was very comprehensive, very good. I think she mentioned most of the important aspects, but I just wanted to highlight the different presentations of fetal or neonatal versus the infantile, and how they are mostly benign in the neonatal period. So that's why we go for surgery first, but we are also led by the AFP. So even though there is a high, there is an AFP in the newborn, there's a graph that shows what it should be. And if it's above that, then you can call it a high AFP, which means that there's more yolk sac elements in it. So that could lead your decisions. Also, the imaging would affect your decisions. And then in the infantile or out of the neonatal period, the risk of malignancy is higher. So you would start off with the biopsy and obviously the AFP as well. And the biopsy will also help you to biologically identify the tumor, whether there's yolk sac elements, whether they are malignant versus benign elements. And you can opt for preoperative chemotherapy. These tumors are very sensitive to chemotherapy and they respond well to chemotherapy, so they will shrink. Most of them do shrink, and like Vuyo had mentioned, the benign elements won't shrink with chemo, obviously. So it does help in a malignant tumor to shrink it before surgery, and that usually takes quite a long time, like 4 cycles. And platinum-based chemotherapy has changed everything for sacrococcygeal teratomas, or teratomas in general. they have much better prognosis because you can shrink them down and make it safer and easier to do the surgery. You do need to remove everything, including the coccyx in the sacrococcygeal teratoma. And then the AFP is a very valuable marker post-operatively. We don't always have tumor markers to go by, and this is one of the tumors that luckily we have something that we can gauge whether there's residual tumor or recurrence. And then I just wanted to also highlight the PR. So any children or infants who are presenting with chronic constipation, how important it is. And I always tell you guys this, but to do a PR, because you can miss a presacral mass, and you see how important that is with this sacrococcygeal teratoma. And then the fetal diagnosis, yes, it's a developing modality to do a fetal intervention. And it is, I mean, we could argue that those 50% of those children wouldn't have survived anyway if they hadn't done a fetal intervention. So that's, you know, it's a developing modality, and we'll see what happens with the data from that. But it does seem, definitely with the child with the high drops from a large tumor, highly vascular tumor in utero, with high drops, most people with the capabilities would offer a fetal intervention. And I think it's a promising route to take and can be life-saving. Obviously, the counseling elements to that are very important. So the parents need to know that, you know, there's a 50% mortality that's associated with the intervention alone. And then just to correct you, it's the median sacral artery, and you correctly said, you know, you might, even without a significant presacral component, you might opt to do an abdominal approach first to ligate the median sacral artery if it's highly vascular, to control bleeding when you're doing the dissection outside on the prone position. And is important for the chemo. So you said that they were mostly stage 1, but then also you said in sub-Saharan Africa, which is completely correct, they are presenting later. So they are more advanced stages. And I know, like, the textbooks are saying they're mostly stage 1 because that's what they see. But in sub-Saharan Africa, definitely there are higher stages in the infantile ones. And it is important to stage them for the chemo, and how long they get the chemo and how long you follow them up. Yeah, I think that's it from me. But well done Vuyo.
Yes, thank you, Yashoda. I'd just like to highlight the importance of examination of the anus and the rectum in an infant who presents with chronic constipation, especially if there is some anal abnormality like anteposed anus. We must put a finger in the rectum. And I remember a case where an well-educated parent's infant had gone from doctor to doctor, and nobody, they had just given laxatives and pagicol, and because Cello saw the patient once and he looked at the anus, and then he diagnosed a sacrococcygeal teratoma, presacral one. There was no obvious external swelling. So these things happen. I think we must keep a good lookout for them. Kululeko, if you can make some comments, please.
Hi, nice presentation, Vuyo. I think you managed to cover everything that's important, and also Prof and Yashoda have highlighted the importance, especially when it comes to examination of these kids, especially the older ones where there is no mass that you can see. So it's very important as well that in a child with anorectal malformation and sacral anomaly, just make sure as well that they don't have a mass PR, which will fit in with the Currarino triad. With imaging, it's also important that when you ask for imaging, that they need to include an angiogram with these kids, so that you can see where the median sacral artery is and where it connects to the aorta, because that's very important, especially as Yashoda mentioned, that with the more very vascular ones, even though it might be mostly on the outside, you might still need to do an abdominal approach to just first get to clamp and ligate that artery. So with that, you can also, if it's mostly on external with a small intra-abdominal mass, you can also use laparoscopy, laparoscopic approach to just get that artery clamped or ligated, so that you don't have to subject the kid to a laparotomy. And then, as Prof mentioned, that obviously the higher the Altman stage, the more the laparotomy is more important into getting into excision of the tumor, because you can't get the prone ones. And very, very important, the coccyx has to be removed, because that's where most of the recurrence comes from. If you don't remove the coccyx, then most chances are you get a recurrence from that. And then, yeah, some of these kids, especially because you're working in a delicate space in the sacrum and in the lower region where there's nerves and muscles, then they do suffer from neuropathic bladder OPA. So that will be further outcomes or follow-up for these kids. Besides just screening them for a recurrence, you must also look out for problems with the bladder and bowel symptoms as well. And then you mentioned went through testes and ovary, obviously just in brief, and not in details as the other one. So also with testes, they usually bimodal. So you either very early, so you're less than 3-year-olds, and then or very late, which is your after teens, so 20 years and up. And also the tumors that they present with are also different. But you mentioned how you go about screening and surgery for those cases. But I think you covered everything that I actually wanted to highlight, with Prof and Yashoda have highlighted.
Thank you, Kululeko. Those were very good comments, very practical ones. I just like to add that MRI is now almost like the most important investigation after ultrasound, and also in the fetal period, MRI gives you very good imaging, and that is quite commonly used. Vuyo, thank you for just covering the testing in the ovary part, but I think we will discuss testicular tumors and ovarian tumors as a separate entity sometime later. So now I just ask Selo to make comments, please, Selo.
Basically, no comments, Prof. We covered the topic quite extensively and very, very well. So I don't want to just rehash what everyone has been saying. Just PR, as everyone is highlighting, is extremely important to do. Yeah, but it's a very, very, very well done on the topic, Vuyo.
Thank you, Selo. Dr. Kopolo, Funeko, do you have any comment?
No, Prof. Thank you, Vuyo, and congratulations on covering this topic nicely. No comments.
Okay, thank you, Funeko, for participating. Anybody else has any questions, any comments? Anyone else?
Can I ask a question? Vuyo?
Yes, yes, please.
Vuyo?
Yes.
What is exit procedure?
Correct.
The full name and what actually gets done.
Very good. I was going to ask. Yeah.
X.
Okay, you need to read, Vuyo.
Exutero intrapartum.
Yes.
treatment.
I just didn't want to miss it.
No, no, that's good. That's good.
Yeah, but what does that mean?
Huh.
What is, yeah.
Now, Vuyo, read about it, and you can, yeah, you can tell us on Friday.
Okay.
What is exit procedure? What is done exactly? It is important to know. And also,
Okay.
I would like you to know a little more about Curarino triad, because that is something examiners like to ask. It is quite a distinct entity in the sacrococcygeal teratoma and related topics. So I think just read about Curarino triad and just tell us in 1 minute about exit procedure on Friday.
Okay, Prof.
Okay. I think if there are no questions, thank you very much for attending. And we had not only Dr. Coppola joining from Umtata, Crystal joining from PE, but Dr. Anna Marie Houghton, pediatrician, joining from home, and Nicole joining probably from Zitulelek. There is one question I see: how do the tumor develop in all parts of the body if they originate from the gonadal plate? Vuyo, can you answer Kirsty's question? How do the tumors
They
develop in
don't,
all parts of the body if they originate from the gonadal plate?
as far as I know, they don't develop from the gonadal plate.
Good.
They develop on their way as they're migrating from the base of the yolk sac.
Correct.
So,
Yes.
mm,
So that's why they can be present anywhere in the body. Usually they are common in the midline. Okay. Any other question? Any other comment? Okay, if no comment, thank you very much, people. I have tried to record both of them. I'll just have to download and then share the link on our department group. Does anybody know who is presenting next week and what topic? Don't worry, you can just put it on our group. Then I will arrange the meetings for next week. Okay, thank you, everyone. Good evening.
Thank you.
Bye-bye.
Thanks.
Thanks and bye-bye.
Bye-bye.